Right. So, good evening, everyone. I hope I'm audible. Can I get a thumbs up in the chat box, please? If it is audible to all of you. Thank you. I'm Pooja Swarup Saxena, Trainings and Scientific Education Lead, Polymed. And on behalf of INS India and Polymed, I welcome you all to the Ivy Talks 26 kickoff session. Quickly in the chat box, you can mention the cities from where you're logging in the chat box quickly. Thank you so much for supporting. Wow, Chandigarh, Pune, Raipur, Bhilai, Ahmedabad, Kanpur, more. Vadodara. Okay,
Wow.
nice. Chennai. Okay, Hyderabad, Pune, Manipur. Wow, interesting. So we're getting people from all around, and thank you so much for joining in. Ivy Talks has got a lot of love and support from all of you. It's been 1 year since we have connected on Ivy Talks. Last year, I remember on the same Ivy Nurses Day, we have the introduction session, and it's been a wonderful journey from so far. Those who are joining for the first time, Ivy Talks is a monthly connect of INS India members. It's a webinar series. Each month, one chapter or one or more chapters collaborate, combine to organize this program called Ivy Talks. We have expertise from different domains in the healthcare setup. They exchange thoughts, they exchange experience, and they share their insights on topics which are of relevance for all of us. And this program has been guided by none other than our CEO, Vinu ma'am. We have Madhukari ma'am here with us, the Vice President, INS India. We got a lot of, encouragement from and yes, and support from all the nurses all across the country. So with this, I would like to take up a small moment to introduce today's session. This is 24th of January 2026, and we are starting the new calendar for Ivy Talks. So this year again, we would be having different chapters collaborating month by month and reaching out to all of you with different expertise and different opinions on topics which again are relevant to our day-to-day practice. And to kick off the 2026 calendar, we are starting with our a round table. It's a virtual round table with the governing council members and the general council members on something which is uh, pretty much relatable to Ivy Nurses Day. The discussion is on the theme of the Ivy Nurses Day 2026. And without taking much of a time, I'll take the pleasure to invite INS India CEO Colonel Binu Sharma ma'am to please go ahead and take up the session from here. Over to you, ma'am.
Thank you, Pooja. And what a pleasure. Beginning of the new year, we are all coming together for a common purpose. Our nurses, clinicians, leaders, innovators, patient safety advocates, all united by a shared theme, a shared commitment, and that commitment is our core value delivering infusion therapy, not just with efficiency, not just with safety, beyond that, with loads of compassion and continuously improving. At the outset, let me put on record my appreciation, my compliments to Polymedicure. They are our associate partners, they are our knowledge partners, and Polymed came up last year with the idea of Ivy Talks. What a catchy title, Ivy Talks. Whether it is Ivy Talks, we all talk Ivy, or is it Ivy itself is talking? Very catchy title. I really love the title when it was suggested. And today we celebrate not just the National Infusion Week starting 26th to 30th across the globe, but we are also celebrating our first anniversary, 1 year completion of IV Talks. Those who have been members coming together month on month, they would realize that every month we have a different theme, we have a different team, we have clinicians, quality professionals, we have had counselors, we have had medical administration, we have had nursing leadership driving it month on month, which means it's completely a healthcare professionals collaboration. Healthcare is not a place where only nurses can deliver and get the goals. They have to come together with all other healthcare members of the hospital, and hence Infusion Nursing Society along with Polymedicure has really come together to drive this collaboration in improving healthcare, improving infusion safety. And also, let me take a moment to thank our nursing leadership at Infusion Nursing Society. We are 15 years old. We just completed our 15 years existence in the month of December in India. We are a US affiliate chapter and we have fantastic nursing leadership. We've got close to 5,000 members. We've got, I think, not less than 400 nursing leaders, educators, quality professionals, infection control nurses, clinical educators. We've got a governing council driving the whole thing. In the governing council, we've got Captain Madhukari right here. She is the vice president. We've got Ms. Dolly Bishwa. She drives our scientific or editorial commitment. She also drives the electronic newsletter, and she's also the Kolkata chair. We've got Ms. Sainu, who is a chapter chair at Hyderabad. She's also a governing council member. She's been long committed. She's the infused assessor for us. Almost many of you are infused assessors. We have Dr. Lata Venkatesh. Dr. Lata Venkatesh is part of the scientific committee. She's a GC member from Delhi NCR. And last but not the least, we've got Miss Madhvi, who is driving the Bombay chapter as a chair. And Miss Madhvi helped us to establish our first ever walkathon last year prior to the conference. And right now, Ms. Madhvi is going through infused audit, which is a quality improvement audit in the field of infusion therapy. So thank you, each one of you, for coming together for this commitment to our webinar, coming together with all other members of the hospitals. And thank you, nurses. I heard today we have highest ever registrations, which is about 700. So, friends, infusion safety may sound really very, very technical. Is it technical? I think at its core, it is deeply human. Every checklist, every innovation, every technology support, every SOP we design around infusion, we have to remember our patients have put their trust in our hands. They come to us, they trust us, and it is that human being, that patient, who is driving us to drive innovations, drive improvements, and make infusion as effective, as great an experience as we can make. And infusion, we all know, definitely IV cannulation is totally done by nurses. It's a most frequently done intervention. Hence, we deliver that experience every hour multiple times as clinician nurses, and also nurse leaders. They definitely make it more effective, safer, and they help us to make the image of the hospital and drive safety, drive infusion along with all of us. Let's learn from the real world leaders. All of you who are participating as speakers today, we will also urge, request all audience to stay connected with us. We have a lot of people already in the call. They can ask questions in between. They will be helped by Polymath team. And let's learn from each one of us together. on how to reduce the risk during infusion therapy continuously and make infusion really, really, really safe and risk-free with better clinical outcomes. With that, I think I would invite Mr. Arun Sondhi from Polymed to give his comments to the nursing team in the new year and a very, very happy new year to each one of you. We are still in the new year, we are in January. Over to you, Mr. Sondhi.
Thank you very much for giving opportunity and thanks a lot for all your kind words. So on behalf of Polymed, I want to extend a very warm welcome to each one of you who are seen here and some people who are not seen on the screen to them also. So very warm welcome and heartfelt gratitude to all our nursing fraternity on this National IV Nurses Day. So my wholehearted appreciation to all the IV nurses for their dedication and commitment, because I have worked in pharma industry also for 27 years in different segments like cardiology, diabetology, uh, interventional cardiology. If any one person who is putting a tireless efforts in the hospital, that is nurses, number of hours, and that precise, and they have to be very precise also in their efforts. So thank you very much for your tireless services. It's been 1 year of launch of IV Talks, which Pooja has already covered. I'm sure it is possible with all your help, support, and guidance. Thank you very much. All the very best, and I sincerely honor all the IV nurses. Thank you very much.
Thank you. Thank you, Mr. Sondhi. And thank you, Pooja. Pooja has been very consistent, very persistent, and must appreciate her passion, if I may say, if not equal to nurses, sometimes more than the nurses. So thank you, Pooja, for driving it, and I really appreciate that. You're on mute.
Thank you, ma'am. But honestly, Ipshita is there. And she has been the backbone of the program. Shinoj, Ipshita. I must name the people who have been behind Ivy Talk. So Ipshita is there, Shinoj is there, Lokesh. You can see it around. He is the one who is holding the Ivy Talks together with from the IT support. We have our Marcom team, Meghna, Arun. They've been behind, and my whole entire MedAffairs team. Dr. Atul Sharma is there. So we have the entire team in there. And from Polymed side, we ensure that we'll continue the support the same way. Over to you, ma'am.
Thank you. Thank you. Thank you, Team Polymed. Thank you, Dr. Atul, for always helping us to drive it together. Thank you, Ipshita, and everybody else. So I think with your permission, shall we just kickstart? Pooja? Okay.
Yes, ma'am. We can. Over to
So
you.
we have an expert panel of speakers. As we just introduced them, we have got Captain Madhukari, we've got Miss Sainu, we have got Miss Dolly, we have got Dr. Lata Venkatesh from Delhi AIMS, we have got Miss Madhvi, and I think and we have Miss Sainu from Hyderabad. So we have people from East, West, North, South. As the program is national, our team is also very, very national. Team of speakers is also very, very national. So let me kickstart with the opening question, maybe to two, three of you, starting with Dolly. We're talking infusion safety. So, Ms. Dolly, what does infusion safety mean to you?
Thank you very much, ma'am, for the questions. Before starting the answer, let me first thanks to Polymed, Dr. Atul, Pooja, Ipshita, and the entire team for having such, roundtable meet. It means a lot. And whole year, you have done plenty of IV talks, lots of gain, or lots, when we circulate the communications to our nurses, those who are actually at the bedside, they get lots of opportunity to understand the nitty-gritty of each and every therapy. So without spending time, thank you for having the meeting. Let me come to my questions. So, ma'am, it means a lot. It means first, patient safety, safety of the family. Second is the healthcare professionals, those who are actually handling the infusions, the nurses, and the doctors, and also safety of the organization. Let me come to each and every point and clarify. Patient safety, if we talk about infusion safety, infusions are delivered to patient. Appropriate delivery of the infusion therapy. If a nurse knows that selection of vein to be done by using a vein visualizer, so that one prick success we can get. If an appropriate cannula is chosen, inserted into the vein, infusion started, should know that labeling of the infusions is very important. Using an alcohol swab for descrubbing the hub is very important so that we'll not introduce any bugs or germs. While handling the infusion therapy, introducing cannula, all safety right from hand hygiene to be maintained and application of transparent dressing for fixation of cannula. So, all those kinds of aspects, if a nurse is flushing of the line using um, a Q site or any kind of connector, which are really helpful for appropriate infusion therapy. Coming to the healthcare professional, if we are using a safety cannula, obviously we can prevent needle stick injury. So in that way, that will save the healthcare professional. If a patient lands up with any complications, obviously, if a nurse or a doctor the patient been filed a case or sue the nurse or doctor because of any complication, that will again harm patient safety, and that will really harm the infusion safety is not been adopted. So the organization also will be in paying a huge amount of compensation if the case goes to the court. So keeping in mind all patient and family member, healthcare professional safety, organizational safety, we need to keep in mind patient's infusion safety is paramount important. So we follow infuse standard. So we have the, infuse certification program in front of us. By doing this, I am sure many organizations in India have adopted all sort of infusion safety program so that patient will be safer, patient satisfaction and delight can be achieved. So this is
Thank
in a
you.
nutshell.
Thank you, Ms. Dolly. Let
Thank
me,
you, ma'am.
you touched upon so many aspects and you are igniting hope in me that I can ask more questions. Let me come to Dr. Lata. Dr.
Sure.
Lata, you represent the academic side and you are in one of the
Yes.
most prestigious institution, which is AIMS Delhi. And having known you for your expertise, for your competencies, for your extensive knowledge, can you tell me, as a principal at AIMS, where you've been for some time and before that your other organizations, uh, why is infusion such a critical foundation for patient trust and for modern healthcare? And what do you do with your faculty and with students to drive anything about infusion?
Yes. Thank you so much for this question because, infusion safety and infusion practices definitely provides a platform to gain confidence among the patients and family members because the infusion therapy is visible, first of all. And normally it takes some time, it takes some hours and the patient will be there under the monitoring of nurses for some hours. And this infusion therapy requires definitely precise professional skills from the nurses. It is not that every nurse is successful. How many nurses get the IV line pricked in a single prick, so it naturally equates the competency of the nurse experience of the nurses, and the patients and families will be watching how precisely we are able to establish the IV line and how we are connected with them in monitoring the infusion therapy. Because 3 hours, 4 hours when infusion is there, sometimes we have seen that when the fluid is getting over, the blood is getting sucked in, So the nurses have to be continuously monitoring when the fluid will be over, when we have to change the IV bottle. So it requires continuous monitoring from the side of the nurses. So what happens when we are having the competency in getting the IV line established with a single prick, and we show our compassion in monitoring when the IV fluids are on, that gains the confidence among the patients and families, and they start trusting them, liking them, and definitely infusion therapy will be laying a foundation for trusting the nurses for rest of the other care. Probably this is one sample exercise which the patients see, and they will start trusting the skills of the nurses for rest of the other activities which they are providing. So coming to our faculty and students, how do we train our, of course, I was also requesting you that we can conduct the Skillathon in AIMS, definitely it is required.
We will do
We
that.
really, yes.
Yeah.
So we really orient them, now, like I have introduced induction program at the beginning of every year. So every year we pick up certain important procedures and we conduct a induction program in the lab using the simulation techniques. We also got now we are coming in. So we use the technology and the latest teaching methodology, and we expose them to the infusion therapy before we are posting them in the clinical area. Especially in the second year, before their second year only, they are posted in intensive care areas and other areas where they are expected to do the infusion therapy. First year, it is limited, So in the second year beginning itself, we conduct the induction program and expose them to high risk medications, infusion therapy, and we sensitize them before they are posted in the clinical area. So that way, this year we have taken up the theme of zero harm. Zero harm of the theme we have adopted in College of Nursing. So all the faculty and student are committed to zero harm. We are making sure that no harm is happening through the practice of the student nurses in the clinical area. So in that, this is also one of the aspect which is being included. So this is how we are working on developing the competency of the student nurses, at the same time ensuring patient safety, that no students during their direct practice cause any harm to the patients. Thank you.
Thank you, Dr. Lata. That brings me to another aspect of it, to you itself.
Yes.
And I have known this issue from hospitals where I have worked, and I'm sure all of the
Yes.
nursing leaders who are in the call will agree on that.
Yes.
Patients are highly educated. At the same
Yeah.
time, they are highly
Yeah.
demanding in the private world.
Yes.
They do
Yes.
not want a student to ever touch them for even IV cannulation. They
Yeah.
don't even want a student to fiddle with the infusion pump or the syringe pump. And even leave alone students when there are fresh graduates coming to work. And we all
Yeah.
have 30-40% of fresh graduates coming
Yeah.
in a
Yes.
constant stream because of the typical scenario in our country.
Yeah. Yeah.
So patients just say, get me a senior nurse. If that
Yeah.
is the scenario, I'll have this question from few others as well. Then
Yeah.
how does nursing leadership deal
Yeah.
with it? If our fresh graduates, if our students don't get a chance to intervene, to do the intervention, how
Yes.
are they going to get the experience of actually doing it, Lata?
Yeah, this is a very good question. Currently I am in AIMS, so here the situation is different. Earlier I was in Apollo. Apollo, you get all patients who expect very high-end care. I think some of my colleagues from Apollo are there.
Premium patients. I'm going to ask
Premium this
Madhu and
one.
Dolly
Yeah,
and Sainu,
yes,
everyone the
yeah,
same question
yes.
actually.
So what
Very
is the
brief, but
system?
I wish to know that. Yeah.
Yes, yes. What is the system I adopted in Apollo was, in the uniform also, we have not shown much difference between a licensed nurse and the student nurse. They look almost similar except a mild color difference. So the patients are not recognizing that this is a student nurse and this is a licensed nurse. Then what we did, we have from the second year onwards, we have started posting the students on all the three shifts, morning, evening, and night, and they started working along with the nurses in the clinical area. It is not that the faculty all the time which who were walking around. We started integrating, we started attaching in the clinical area. Then what happened? The working nurses, they started owning. They really liked a few students. They wanted only the same students to be continued to be post. That way we did it. And for the faculty also, what we did every year, we made mandatory practice of 15 days to 2 weeks to 4 weeks. Without students, they have to only work in the clinical area during the vacation period. So that way also the faculty were also taking up the responsibility and getting themselves oriented, and they started interacting and developing very good relationship with the nurses who are in the clinical side. So these are the
Got
two
it.
measures which were very helpful, and
All right.
internship period is also very, and in AIMS, it is not necessary to say you have 20,000 OPD patients coming every day. All the OPDs are busy, and if you look at the treatment area, or injections and infusions, and in the clinical area also
I think
overflowing
AIMS
patients.
is a little
Yeah,
easier
yeah,
place where these demands
yeah,
happen.
yeah,
Let me
yeah.
come with the same question to Captain Madhukari
Yeah,
and
thank you.
Sainu and Dolly, but in very brief, one minute answer. How do you tackle this particular thing? Inexperienced or fresh graduates, or sometimes students coming in from the colleges? How do you tackle this, Captain Madhu?
Thank you, madam, and thanks, Polymed, for giving us this opportunity. I'm sure that we are going to create a difference by discussing these practical problems that we face day in and out in our every organization, and the nursing shortage, the competency difference, the gap that we have. All of us have the same challenges, but how to overcome it? We can take some points from each other and make a best policy out of it. So, just going to the topic, that I want to say that that some certain things are to be adopted or to be evolved in the system, that we know that we have shortages. At the same time, these student nurses can make a difference, but who and how, that is more important. So to check a process, check and process, balance process has to be established in the system. Like, these students, when they come, they have to be observed for the things that they do, and we have to do a competency check for them. I do not expect a second year nurse, second semester or the fourth semester student doing this, but if definitely when the students are at final year, they are the ones who can be taken for the skill check, and we can see some of them who are fast learners, who have good skills. So
Hmm.
we can prepare a core team of students, and we give them in the clinical field by our clinical educators. We do that practice. We give them a capsule based training for them, simulation in the simulated area, simulated environment, where like we are able to give them a controlled environment, and we are telling them what to do and what not to do, and checking their competency, and giving them those tips which are very important. Probably they have the best skills out of all other students, but they don't know the main tips which have to be actually a guide, that will be a guided principle for them. If that is
Okay.
given, and we check, they make them do the hands-on practice in front of us under our supervision for 10 patients, maybe that is the best method. We have seen very good impact coming, and then there is no differentiation between the staff and students. So that gives a
Thank
very
you.
good
Thank you,
result.
Captain Madhu. A lot of good points I'm seeing. Identifying the high potential, getting them ready with skills, a competency check, supervising, evaluating, and getting them engaged into IV cannulation. I think these are some very good strategies because we will always continue to have fresh graduates and students during internship. Is there any other aspect to the same question, Ms. Sainu and Ms. Dolly, you would want to add?
Thank you. First of all, I would like to wish all of you a very happy new year. and Ivy Talk anniversary wish. Basically, when we have a cover page having a news being repeated, we very well get interested into it. And Ivy Talk is doing that, keeping infusion at the top of every state's mind. So we wish that, we'll be continuing it with a more rigor around. Coming to the question, and as Dr. Madhukari has already mentioned a lot of points around it, and to ma'am's point, I would like to also add, like when we have a shadowing done from a senior nurse for the students, along with this also helps them to build up the confidence so that by the time they are really on the phase that they are going to handle a patient independently, at that phase they will be more confident in doing it. And transparency to the patient also sometimes help. May not be in the government setup because patients don't know, but in the private setup it's nice to know that this is a student and this is a staff nurse, but the students are able to cope up and build up their confidence and their rapport in such a way that the patients do want the students also to come forward. So we do feel there is an individual competency difference and communication difference which students come with, and they get accepted by the patients as well. So that approach also
Great.
helps.
Thank you, Sainu. Dolly, anything different you
I
wish to
just
add?
would like to say, yeah, one thing, ma'am. These students, they learn on a simulator, they learn on a mannequin. So, when they comes to an actual scenario, they have to be taught that this is a cultural shock to them, first of all, changing from bedside to actual scenario. So, doing biculturalism. Now, how to do biculturalism from mannequin to actual scenario? It is only possible when the senior takes a load of hand holding the juniors at the bedside by showing them actually how to hold the cannula, actually how to remove the cap, or to keep in a nice and a sterile field, or how to use the alcohol swab to do a scrubbing the hair. So these only can prevent the fear. They will be able to balance the biculturalism, and then they will grow up. Whether the
Okay.
bright student may pick up little early, and little bit of those who are little lesser than them may pick up little late, but this hand holding is very very important, which we see
So we have
sometimes
hand
seniors are.
holding,
Yes,
evaluation, competency,
correct.
checklist, getting
Yes,
them ready when they come,
correct.
supervision, identifying high potential, a lot of points. And I think all in the audience will be gaining confidence from that. From the Infusion
Absolutely.
Nursing Society, I would only add something. We have started for last 2 years or so engaging with nursing colleges and doing hands-on skillathon with the help of INS partners. We have started doing hands-on skillathon for peripheral IV cannulation. In fact, they want us to go beyond that. They
Yeah.
want us to do on central line and all other things. But IV cannulation, we have done hundreds of colleges in the last 2 years, and students are becoming so enthusiastic because they get the hands-on experience, they get the knowledge, they have a certificate, they already have, I would say, 60% of confidence in them before they reach the hospital. So that is from the INS India. And I think that was a great question. And let me, I just saw a question from the audience from Ipshita. How many pricks are allowed by a trainee nurse? Is that right, Ipshita?
Yes, ma'am.
Ipshita, is
Like,
that the question?
ye- yes, ma'am. Actually, we are giving the training by the stimulator or dummy arm. So, like, how many pricks we can give them allow to do
On a
the?
dummy arm, as
Yes,
many
ma'am.
as they can have
As many
hundreds of
as.
pricks on a dummy arm. IV arm is not expensive. It's a very valuable resource. It is easily available in India. There are so many brands. They can take their own time. Let them become confident. Dummy arm almost replicates a human arm. So they can have as many pricks as they think they feel confident. There is no limitation on the numbers. Moving on to Sainu for the next question. So we are already listening to infusion related thing. Ms. Sainu, what are the most common infusion related risk patients face today? And
Yeah.
how can we prevent them or minimize them? Could you add something? I think we have to be a little brief in our answers for everyone, that
Yeah.
is, because I have a couple of questions and we have only less than an hour time. Yes, Miss Ainu.
Absolutely. Thank you, and good that we are also touching on some knowledge perspective in terms of the complications here. We all know but I would just refresh it for all our sakes that infusion-related reactions are the prime, which happen when when a patient undergoes infusion therapy. There are localized site complications, where infiltration takes 24% of the cases, phlebitis and thrombophlebitis takes around 15% of the complications. Extravasation happens. Dislodgements and occlusions take around 90% of the cases. There are also systemic complications, which include infections, sepsis, catheter-related biostream infections, as we all know, because of the contamination during the insertion or the maintenance or to the leading of infections. Fluid overload is something, excessive administration of the fluids can cause a quick, related concerns related to the cardiac as well as the renal concerns. Air embolism is another complication which the patient faces. Thrombosis happens. Apart from this, manual errors can lead into complications of medication errors, wherein the wrong rate, the flow errors, wrong dose or a wrong medication, incompatibility because of the mixing of highly vascular medications, multiple care givers handling the medication, say it is through the pharmacist, the clinical pharmacologist, then the clinician or the nurse, that could be a factor. So key important factors which could, risk is the age of a patient, the medication type that is going on, pre-existing condition of the patient, something called a first dose phenomena, where we don't know how the drug is going to react to any single patient. Every single time it is the patient changes, the medication type that it is in, and the patient related factors. These are some key factors which could be there, and the complications which the patient faces because of the infusion therapy.
So,
Now, how
Miss
do we
Ainu, you
anticipate
list.
in?
Sorry.
Yeah.
Okay, go
Yes. Yeah.
on. Yeah.
Yes, please.
I was saying that you listed a lot of complications.
Yeah.
And to many of the young nurses who are in the audience, may really be thinking, oh my God, such a simple
Hmm.
procedure like a IV
Yeah.
cannulation can lead to so many things. I wish to ask a question. Can a complication of peripheral IV cannulation, to say the simplest procedure we talk about, can that lead to an adverse event or a sentinel event? Can that?
So, any incidents, if it is considered not very tragic, no, if you don't have the concept of no harm to the patient, we can always overlook. There's something called as an alarm fatigue, which all of us face, and as we come into the profession, we should all learn this, that sometimes we are so very we just don't give that eye to it, that it is going to make a difference. We keep on doing things, and I know when patients, so many patients we see with the years of practice, sometimes our attitude and behavior leads into a way that we overlook certain things, and yes, it can lead into a adverse event. It can definitely lead into a
So
sentinel
I
event.
was
It
going,
can.
my question was that, yeah, we have alarm fatigue, we become monotonous in doing what we do.
Absolutely.
We start accepting small errors as a routine procedure. But what I wish
Right.
to ask Captain Madhu, uh, can a IV complication lead to a sentinel event? If so, then what would that be? One sentinel event which arises from a IV cannulation, or Ms. Dolly, both of you can answer, please, one by one.
Yes, madam. Let me tell you, it can reach to sentinel event. I'm just giving an example. It can happen. It may happen like that at bedside. I have just started a chemo drug, and then I did not go for to observe it frequently. What has happened is that in the bargain we see that it has not gone. But even though the cannulation was checked before starting, even though the vitals were checked, even though the flushing was done and found the channel is patent, despite which the chemo drug can go with extravasation. And if we have not done a check process frequently, periodically, what happens by the time after a long time I go and see either the infusion has gone very fast, which led to complications at the cost of patient has gone into, anaphylactic shock, or patient might have gone into arrest because the fluid has gone so fast, the chemo drug has gone so fast. It is supposed to be going for 22 hours. It has been already finished by 4 to 5 hours, which is detrimental to patient's life. Secondly, if it is going very fast, and that way that rate, of course, the intima of the vein cannot take that load. So that is a way that again extravasation occurs. So extravasation again will lead to even doing it. Even we have seen that extravasation leading to amputation. So even that is a sentinel event. So
I was
these
coming
things,
to
yeah.
that for the audience. Thank you, Madhu, for bringing both of this. With the drug flowing at a very high speed, when monitoring is not done, it can lead to anaphylaxis. There can be extravasation, especially in neonates, especially in pediatric. We have seen extravasation, necrosis, gangrene, and by the time somebody has seen in the morning, this happens most at night. Neonates and pediatric group have lost their arm because of that. That is a sentinel event, loss of a primary organ. So this was something I wanted to just put across in the minds of the nurses who are in the call, that be very careful. IV cannulation can lead to major adverse events. It can lead to also sentinel event. It is not as simple. Hence, please use technology support. Please use innovations. If you have shortages of manpower, then lead yourself for innovations, technology support for monitoring the IV. But monitoring the IV is a must. And in today's time, patients are in single rooms, double rooms. You don't have a direct access to what is happening in the room. You are too busy. You are managing 7, 8, 9, 10 patients. Everyone is on a IV, somebody is on a blood. Please find technology support from your leadership. Raise it to your nursing leadership that we do not want unsafe infusions. Let me come to Miss Madhvi, who just
Ma'am, one more thing in this regard, I want to just highlight. In recent past, we have gone through many shares. I thought that I should ignite that thought in the audience. Many a times the infusion pumps are also coming, with the
yeah,
latest technology,
that's
with the latest
technology. Yeah,
advancements.
yeah.
Advancements. So
I have
knowing
a
about it,
question
I'm
on
telling you.
technology and advancement adoption. I have a specific question which I will touch upon with many of you. But definitely, if there is something else you want to add here, Madhu.
Yeah, just like that. See the infusion pump, which is coming with the set that we may not be knowing unknowingly we have not changed the mode of the infusion pump. We have kept it in volume mode, but we are setting it at rate per rate per ml per hour.
That's lack of
That is
awareness.
dangerous.
Yeah,
Yeah. So
yeah, yeah.
we should know what actually we are doing, what we are using is very important to save
Sure.
for patient
Let me
safety.
come to
Yeah.
Madhvi. Miss Madhvi, today you have a infuse assessment happening by an external assessor. So I will ask you something. What skills and competencies are most critical for infusion nurses as well as clinicians? You've gotten your hospital team ready for a infuse assessment. I wish to ask you, what are those basic skills and competencies which are essential to be an infusion nurse? And do clinicians accept your young nurses? What kind of a reassurance they want? You are in the operational field. So please tell us, Miss Madhvi.
Yeah, very good evening to you all, and thank you, ma'am, for this question. So, just relieved, we just finished our Infuse closing meeting, and to be very honest, the entire experience, the journey for last 6 months was amazing. We came up like the collaboration with the clinicians. The clinicians when they realized that we are going to work on all these things. So, right from competency assessment to privileging of the clinicians, we worked from that part also. So when we said we for the nurses we are going to do that, and we are expected as per the infused standards that you have to do that. So there wasn't, to be very honest, we have a very senior consultants on board with us, but when we opened up and shared these things, they were very welcome, and it was kind of ready to adapt these new things. And when they realized that it has going to be such a structured, a structured approach towards a basic thing that we call as an IV. So would like to share with you all the simple skill. When we were saying, ma'am, before that you all were saying that the nurse needs to be very skillful in the IV and all. Just in the research, like would like to share with you all The awareness of IV complications, it's not only should be limited to the nursing team. It should also be at our receiving ends. Like our patients come for follow up, they come for blood collections, they come for just OPD registration. So we just had a recent past, we had an experience where a patient came just for a collection, a routine collection checkup, and the OPD reception registration girl, she saw a hand wrapped up, and she just casually asked, what has happened? And that patient opened the hand, and we realized that patient was discharged 2 days back, and it was this mild swelling, redness. She immediately escalated that to the right person. So it came to us, and we could intervene, and we could stop that from further deterioration. So I would share with the group, all the learned people here, that we later on in one of our culture awards, we actually awarded that OPD reception person who knew that this could have been some major IV complication. So that is my say into this, that it's not only should be limited to the nurses, even our OPD part, where the reception registration desk or whatever the other than clinical people should also be aware of this, because patients get discharged after a IV therapy or a thing, and they don't know certain things, they're not aware, and they come back just to do OPD follow up and they go back. So sometimes they meet, sometimes they don't meet the clinician or the nurses. So that's the part.
Okay, Ms.
Thank you.
Madhvi, thank you for bringing this up, that monitoring patients even after discharge. I also know of patients with a lack of awareness or a bit of carelessness or negligence who've gone home with a cannula where they did not need to have a cannula. And they came for their follow-up with that cannula in situ. Okay, I've got all the panelists, and I have a question for all of you, which you must answer in 1 minute each, starting with Dr. Lata. What are the technology advancements to improve infusion practice? There's something which you have adopted very recently at AIMS or at any other place which you know of, which can ease out, which can improve efficiency and ease out pressure on the nurses. Dr. Lata, you are on a mute. Kindly unmute.
Yeah, one is simulation-based practice. Like we have purchased enough IV arms, and then they are practicing. And recently, in the IV arm also, camera-enabled IV arms have come, and some companies have approached us where no faculty need not stand there. The camera captures all the critical steps and non-critical steps, and it is AI-enabled, and their practice report comes. So that way we can save a lot of time depending on the technology, monitoring the students' practice, not only for IV cannulation, even for other procedures also. Camera-enabled mannequins and camera-enabled task trainers are coming.
Thank you. Thank
which
you.
will
I'll stop,
evaluate.
I'll
Yes,
stop
yes,
you here. I will ask others to add
yes,
another innovation. Anybody,
yes.
Sainu, other than the camera-enabled IV arms? Anything else
Yeah.
you would want to add, technology
So the
advancement?
So the infusion pumps which we are using with respect to the time advance, specifically with chemotherapy, that we are, very frequently using, and in fact using it for 100% of our patients there, and the data analytics which attach to the EMR. So it helps us to
So
understand
smart
if there,
infusion pumps
yeah,
along with data
data.
analytics.
So
Thank
if
you.
it had been like there will be multiple cycles of chemotherapy when it comes
Short,
to
short,
to the
short. I have
yeah.
loads
So
of
if there has been
questions.
a reaction
Captain
in the first,
Madhu.
second cycle, we move it across. Yeah.
Okay. Captain Madhu, any other
Yeah.
technology advancement you want to tell the audience apart from
Yes,
these
yes.
two?
There are some wearables and portable infusion devices are also available, which actually helps in for outpatient settings mainly. That helps in designing and enhancing safety protocols for accurate drug delivery and the way you set it. So it really helps, and you can monitor it. It can be that app can be linked to your device, your watch or your
Fantastic.
mobile, and
So for drug
you'll be able to
delivery,
actually monitor them. Yes.
very good. Drug delivery devices, which are wearables, which mainly help for patients at home or remote monitoring. Miss Dolly, anything new you wish to add?
Yes. Ma'am, almost everything is discussed here, but we have adopted smart infusion pump. Along with that, we have got recently a very high resolution vein visualizer. which
Fantastic.
is, yeah,
I was waiting
which
for
is
vein
helping us in
visualizers. Yeah,
one prick success.
one
That
brick
is,
success.
yeah.
So
So that's the
audience, keep
technology.
listening. You have to push your leadership for adopting some of these things. Miss Madhvi,
Right.
anything they missed out, or is it
Yeah,
all?
they almost covered, and Dolly ma'am just covered. So in this, currently, as we were going through the infuse, we have ensured each department has a vein visualizer and a very high
Fantastic.
resolution one. So that has been a very boon to us, and we are successfully moving towards the first brick success.
Madam, overall,
Great.
I want to
So
say
I
one thing.
will,
One thing
sorry.
I want to say, one thing overall I want to say one thing is that with AI technology that we have now, the predictive analysis and risk scoring is very easy now
Very
with AI
easy.
technology to implement, so that we can take out who are at what risk and accordingly what type of precaution beforehand that we should take.
Fantastic. I will
Absolutely.
add one innovation which did not come from my expert panels. There are monitoring devices for IV. When patients are in the room under the closed walls, there are monitoring devices which can be attached to the IV fluid which is flowing. A nurse can set an alarm at what volume she wants an alarm at this nursing station. It can be 30 ml, it can be 40 ml, it can be 50 ml. Highest anxiety what a nurse and a patient and his family go through: when is this IV finishing? Will the nurse come? Will all the blood go back into the bottle patient's blood? What will happen if the nurse doesn't come on time? They keep ringing the bell. Even when the fluid is about 100 ml left, they keep ringing the bell. So there are now technology support. This is the recent one I know is an innovation from IIT Madras to IITians who are non-healthcare people, and we had invited them. In fact, we had adopted it in my organization for room patients, and there is a very simple device which stands on a bottle and you can monitor, you can get the alarm. And so these are, I just wanted to align the audience for what is future of infusion therapy. We all know there will be shortages. I'm coming to the question of
Yes.
shortages now. So we know there will be shortages. We know there is high clinical equity. We know there will be epidemics of disease. There are COVID, there are situations of dengue outbreak. We know we will go through staff shortages, high attrition, whatever leading to shortages. So we need a lot of innovations and technology support where the care continues to be safe despite less nursing numbers in the roster. That will give a lot of relief to the nursing leaders in the audience as well as on the panel. That will give a lot of reassurance to the patients. It will entrust our clinicians that things are in control, and it will also relieve our young nurses of the stress of running to the patient room. You know, all the time they are thinking, is that IV finishing? Is that blood finishing? Is this finishing? So these are some of the advancements in technology which are going to make our life simpler. Okay, let's come to something for many of you. Uh, Data analytics, somebody did touch upon. So let me take up a question on compassion, staff burnout, and how to ensure safety despite and still not increasing the stress of the staff. We know infusion is a constant process. Either there is IV into peripheral IV, or there are central lines, or there are arterial lines, there are dialysis catheters, and all the time we nurses are running from pillar to post in managing this. So let me start with Dr. Lata. Dr. Lata, what do we do to keep the burnout and the stress under control? How do we extend this compassion as nursing leaders? That safety is important. At the same time, the staff is
Yeah.
also not going into stress and burnout because they don't report. We know our staff. They may or may not report their stress and burnout. They are all too busy recognizing their burnout. and how do we control it? Some one
Yeah.
measure, each one
Yeah.
has to be ready with one measure.
Yeah.
This is a question which impacts all nursing leaders, which impacts all hospitals. So I really wish to ask everybody this one.
Yeah. I would say rewards and recognition, feedback from the patients when they have done well, that will really make them happy and reduce the stress. Apart from having safe staffing level technology support, rewards and recognition, no
Rewards and
adverse events, give
recognition.
them a badge. And yeah, that will
Fantastic.
be an
Miss Ainu.
encouragement for them.
Miss Ainu.
Yes.
For what worked for me, I would say quality circles work for me. So there are like, small 10 minutes discussions at the beginning of the shift every day, where the previous day incidences and all are also being discussed. And very, very neutrally, they have been heard across too. And they themselves will also say, let's do this, because I think this would have been a better way of doing it. So their ideas are coming up, taking it up, implementing, and of course, adding on to the R&R. But involving them into the decision making helps. So they are heard. So everyday basis heard, not just in a
Okay.
monthly town hall or things like that. But that
Miss
works.
Dolly. Miss Dolly.
Yes, ma'am. What I feel like continuous training and by in-service education and at the bedside, train them. I mean, pat on their back with their good work and a note of appreciation to them. And of course, the patient feedback when we share, that's all, motivates and it releases their stress as well as burnout. And definitely technological adoption, which will also reduce the energy to run pillar to post and take care of patient if they gets anything on the a nursing station monitoring and understanding when the infusion gets over, and immediately they will go and take care of disconnecting the line and keeping it flushed. So these all are the things which are actually helping
A lot
and
of training
rostering
and
them
technology
properly.
support, you are saying,
Correct.
to reduce
Technological
the
support.
burnout
Yeah.
and the stress.
Yes.
Captain
And
Madhu. Sorry, you have something more to add, Dolly?
yeah, I would also like to say, as a nurse leader, we must see that rostering of the nurses has to be adequate, and there are right time replacement that is also required.
So we're touching upon the HR aspect. Okay, Captain
Yeah,
Madhu.
to some extent. Yeah.
Yeah, I think we are discussing on the shortage. Already we have shortage, we accept that. And then what is the remedy that we
Yes,
can have?
yes.
Yeah.
So with that,
Despite
I think
shortages, safe
this,
infusion, yet not
yeah,
pushing the
exactly.
nurses in a stress situation.
Yes.
For me, it works really good that when you take the ownership of the incidents that happens, do an incident analysis and with the team that whoever involved in the process, and then percolate it down the line and share the learning opportunity for them, for everyone, is very important with each and every incident. That is very important because that gives a wider scope for all of them to learn and see that if the same practice, same error can be prevented. That's despite whether you have shortage, you have whatever, but you just create a learning platform without any punitive action. That's very, very important. Punitive
Great.
action is never, it doesn't work. So, learning is always better, and learn and fun is always a better approach. I feel that that really works
So
wonders.
I would add to this, it's a good aspect. Don't scandalize the nurse who made a mistake. That will push them into more anxiety and burnout. No punitive approach, we all say, but ensure as a nursing leader you stand by your team that they are not made to be either fired or suspended or fined or whatever else. Uh, that does not improve your infusion practice at all. And is there I wanted to quote an incident, but before that, Madhvi, is there something else you will want to add here, some different aspect, what our panel has not
Yes.
spoken?
Yes, ma'am.
Yes.
So, what really worked for me was adopting, rather than adopting a compliance safety culture, adopting a care base. So, this care is for it is like a care based culture by being empathetic leader, implementing a just culture, no blame, as you rightly said, a no blame
Hmm.
culture. So, and that again, integrate well being into safety protocols.
So
So,
it is
these all.
not who did it. As nurse leaders, we are all very fond of taking explanations. Don't go to who did it. You have to see how can it be prevented for future. Whoever did it should not matter. That person did not know. These are not intentional errors. But moving forward, looking at future, how can we minimize these things and we do not have repetition of the same thing? I think that helps in putting a lot of reassurance in the young nurses. Otherwise, they get scared of the nursing profession itself, that there's so much of punitive approach, there's so much of stress and burnout. I will want to quote an incident on staff shortages and this and that. It just about a few years back, I had gone to one of the hospitals. I was managing a chain of hospitals. I'd gone to the hospital in the afternoon. I was walking through a couple of floors. One of the floors used to have only two nurses, with a small floor with 7, 8 patients, a gastroenterology floor, I remember. So, but that day I did not see any nurse at that time, 2 p.m. There was a doctor, and the doctor is chairman of the specialty of gastroenterology. He's sitting at the nursing station. I asked him, Doc, where are the nurses? He said, I have only one nurse today. Another nurse is not feeling well, so we sent her off by 12ish. It was at 2:30 p.m. I said, okay, and where's the other nurse? Because there were 5, 6 patients I could see on the wall, on the queuing list. He says, it's already 2:30. She's not taken her lunch break. And she was not wanting to go. I told her, you please go. 15 minutes break. You have your lunch and come. I will monitor the infusion which is going on in that floor. I'm sure many a times you all have witness these in your career some way or the other. Very rarely we find a chairman of a specialty taking his time off for 15 minutes, sitting on the floor to monitor an infusion, relieving the nurse for 15 minutes because she did not have her food. And I was so impressed. I still remember the nurse who came back. Somebody told her, Madam is on round. And she came back running. And we sent her back that, please have your lunch. But I remember the doctor. I remember the nurse. And I remember how many of us, as nursing leaders, nurse supervisors, I'm not even expecting it from a doctor, as clinical educator, clinical instructor, how many of us really have that empathy that, see, my nurse is alone. Let me send up for a tea break or a food break, and I can be here for 10, 15 minutes. We all have gone through the bedside nursing. We have become nurse leaders. So I think I wanted to emphasize this point for the audience, that there are examples of excellence, of compassion, of support. Create it more and more at your workplace, because that will drive excellence in this world of healthcare, which is full of depression, anxiety, stress, dynamic changes. But keep that going. And as a nurse leader, don't mind putting in a cannula when your nurse is scared to put in. Just stand there and put in. We should take pride in staying clinically competent, and at every level support your nursing team. So we have about
I
10,
agree
12.
with you, ma'am. We have seen many a times when we are involved in the process, when clinicians also get involved. And
Yeah, they
they
will get
actually
involved.
support. And then when you are standing, they support nurses as if nurses
Uh,
belong to them. So we have
yes,
seen that difference, So
Yes.
that
they.
really makes
I have
wonders.
seen
Yeah.
many examples, many examples. This was just one I wanted to quote because I remember that the patient was undertaking an infusion which was for 4 hours, and the doctor relieved her. Nursing support is lacking in private hospital. Yes, I do agree. That is why we are discussing that how can we support our team? Training is fine, skilling them is fine, giving knowledge, protocols, checklist, double check, SOPs, infusion standard of practice, infuse assessment, everything is fine. What will drive safety for patients is also care for your nurses. We have to
Yes.
care for them. Getting them ready is our job. It's not their fault that they can't put a IV line in one attempt. Somebody asked me how many attempts for a patient. I saw, I think, some question. I would only advise that when a nurse thinks or anticipates it's a difficult infusion, she should not make an attempt.
Yeah.
She should get a senior one. And if she thinks she can handle it, she tries it and there is a failed attempt, she should not attempt second time. She gets an expert nurse, an infusion nurse, a IV nurse, and once two attempts are gone, one by a junior nurse, one by a senior one, if that has happened, then
And
get
Madam,
a
Infusion Nurses
clinician.
Society, yeah, Infusion Nurses Society has driven it earlier also about
Yes,
DIVA. So making the
yes.
difficult cannulation
Difficult
champions is
cannulation,
very, DIVA
absolutely.
champions are very, very important.
So
They
make
become,
your difficult
go-to
IV
person.
cannulation champions
Mm,
in every hospital.
yes.
We will really advocate it strongly. Get your infusion nurses ready, numbers based on your patient volumes. And they can't be only in one shift. Some hospitals I've seen two IV nurses for a 400 bedded hospital driving during the day.
No,
What will
that will
happen?
not be
Please have
sufficient.
them round the clock, every shift, Sunday, holiday. You should have that many numbers certified as infusion nurses. I am, we are at 4:40. I'm coming to some more, one or two more questions. What one major change could make infusions better in future? One major change, each one of you, we can start with anyone. Sainu, I see you. So what one major change can bring about safer and better infusion experience for nurses and patients both?
Yeah, I think one mindset change in terms of the practice of a nurse is to have a line on line monitoring. If they are always conscious about the perspective on how many patients I have who are on infusions, and for those patients, they have a specific prioritized way of rounding, which is a personal approach which they look into. So that mindset is very important. Those who don't have a line, they have a different intervention, but those who have a line, they themselves set up a protocol in terms of how often are they going to monitor a chemotherapy line, a non-chemotherapy line,
Yeah,
a
what kind of
pediatric line.
line it
So
is, and they set
yeah,
up a
line
checklist
on line
or
monitoring,
protocol.
yes, absolute.
Line
That eye
on
to
line.
detail, that works.
Okay, Miss Dolly.
Ma'am, what I feel, when a nurse comes and joins with us, they must undertake the certification course by doing a number of cannulation, maybe 20, 30, they will do on job. And then the nurse has to get this certification. Yes, as like US or the developed country, unless and until you get license of doing an IV cannulation or making an IV channel or monitoring a patient on varieties of vascular access device, unless you get certified, you are not allowed to do, continuously take up that role. So these kind of something we have to adopt, and before their confirmation, and then only we will be able to raise the bar. That what I feel. For that, every institution must go for a high fidelity mannequin where all kind of access are available, where nurses will practice it, and then actually on the mannequin or by doing a skeleton or any other approach, and then practice on in actual scenario. We have to see, certify them, and then go ahead, leave them alone to do the procedure. So these kind of
Fantastic. So
something
what I would say,
concrete
what you are
on,
pointing out,
yeah,
that certification and privileging them for
privileging,
various, privileging
absolutely,
them for various infusion therapies when
yes,
they are already evaluated for a peripheral IV, then they are privileged for that. When central line, then they're privileged for that.
correct.
Likewise, right? Yes,
Yes,
definitely
yes.
that should be a futuristic approach for every hospital, for every nurse leader. Miss Madhvi, you are on, you have to unmute yourself.
Yeah,
So
yeah, there. Okay,
one thing in future
hello.
that can change infusions. Yeah.
Okay, so one thing what I see is I agree with the training, having a high-end mannequin. I agree with all that, including that we should have inclusiveness of the patient experience. It's very important to know our training, our skill-based programs are effective. And the best thing that can happen is through the PIVC prems. So when you get those prem done, we actually get the real, the real analysis of our effectiveness of our training. And it's really helpful. It's very helpful because when the patient tells us, okay, this was painful, this wasn't painful, and inclusion of the patient and their relatives for it.
Very good, very good. Thank you, Mr. Sondi, for giving us compliments. Captain Madhu, one future thing that can change the scenario of infusion therapy.
I think best is that we all scenarios are not same, or all organizations also don't have the same need, same gaps, or same protocol to follow. It is that I know my organization, my gaps very well, so that I can do a very structured protocol based training for them, which will help them to learn first before they are put in through the system. That's very, very important. And just by teaching them once, if we feel that they have learned, that expectation should not be set. We should be able to ensure that they have learned it in practical scenario with confidence and with skill.
Yeah.
Then only we should allow them to work and not
Absolutely.
otherwise.
Thank you. So I will come to the closing remarks from each one of you. Closing message for nurses, for nurse leaders, for educators. One line closing message, if there any of you want to say, and if Shita, if there are more questions, we have altogether 10 minutes. Yeah. So somebody is asking, do we get a certificate for the class? I don't know which class you're talking about, but if you're talking about a training program from INS, yes, there is a certificate. If you're talking about today's participation, I don't think we have a certificate for attending IV talks. That's just a webinar. So one closing message from each one. Start shooting. Dr. Lata, are you there? I think she'll
Ma'am,
come back.
before closing remarks, there was a question in the chat box that what are the quality national benchmarks for IV complications? I have
Yeah.
seen that. So I thought that this is to be
Okay,
answered
please
because this is
answer.
very,
Please answer.
yeah,
Yeah.
need answers. One thing is that we all know CLAPSI rate is available we have the, not only national but also international benchmarks available everywhere, CDC, and we have like all these are giving us benchmark. But yes, for other IV complications like phlebitis, thrombophlebitis, I think we can go ahead with our internal benchmarks. We can have that. INS can come up, INS India can come up with a repository so that we can start having our national benchmarks in the in future, near future, so that we
Sure.
can create a benchmark for ourselves in the nation.
Yeah, for phlebitis and for many, CLAPSI has clear-cut benchmarks from CDC, from INIC, but all other complications have to be decided by the hospital based on their baseline data of 1 year, then second year, then third year, taking up averages, raising your bar every time and setting up your benchmarks. But we as INS body can still come up, and I will pass this to the technical committee. I've got two of you from the technical committee already here. I think Sainu also in the technical
Sainu also.
committee, right? Sainu?
Yeah.
So we
I'm
can
there.
come up with suggestions on benchmark, and we can help hospitals devise their benchmark. So Dr. Lata, I think we got everyone. One closing comment, anything which we have not touched upon. We did not touch upon involving patients, empowering patients, patient family, educating them. but that is a given for everything, so I did not take up that point. But closing remark on anything to do with infusion for a future approach from all of you. We are almost at the end of the session.
Yeah. Yeah. I would say it is a shared responsibility. It is also a typical area for interdisciplinary practice and to show compassionate care to the patient. It lays the foundation, as your first question went on. It lays a foundation for compassionate care.
Fantastic. Okay, Miss Madhvi.
So here I would rather say, like, when you want to really, I would recommend again, since that I have just a very wonderful experience with Infuse, I would rather say many of the hospitals should go for this accreditation. So all that we spoke now, what we spoke structure. So amazing leaders who are also part of this meeting now, who have actually formed this and given the inputs. So it actually takes you step by step towards excellence of the IV practices. So I will
So you
recommend
are
Infuse.
advocating for Infuse by the hospital to raise their standards and raise the bar for infusion safety, infusion efficiency, and patient experience.
Yes.
Thank you. Captain Madhu?
I feel, madam, it is very important for nursing leaders to ensure that we normalize the safety behaviors amongst our nurses. We may be knowing what we are supposed to be doing, but we may not be able to practice it. Maybe resource crunch, maybe within the resource availability, we have not told them what can be the best one that you can do safely, so that that can be. And even if we know it, are we able to practice or not? That safety behavior, inculcating that into our blood and nerves is very important.
Fantastic. Changing the behavior of team and safety, adopting the safety culture. Miss Dolly, you're the last one on this.
Yes, ma'am, I would say that continuously empower nurses to adopt the best practices of infusion therapy so that we can ignite all together the hope of patient safety. That is what my message for
So we are
infusion.
talking here igniting health, igniting infusion safety, inspiring hope for
Yes,
safe,
by
effective,
empowering nurses.
compassionate infusion care, which is continuously improving. And thank you, ladies and gentlemen. Thank you, our expert panel. I would invite any comments or anything further from Dr. Atul, Miss Pooja Swaroop, and from anybody from the audience. We have got a few minutes, 4 or 5 minutes left with us. I've enjoyed interacting with each one of you, although I circulated a lot of questions, how I behave. I only take 30% of what I write and send. It always happens extempore, but all of you were great speakers. Thank you. Yes, Pooja and Dr. Atul.
No, we said we were on testing, so no problem.
Yes, it's always that. That's always more exciting. Yes, Pooja.
Ma'am, Miss Merikuti from Guwahati chapter, the chapter chair, she wants to contribute from her side.
Yes,
Mary
Miss
ma'am, you
Mary,
can
come on in.
unmute yourself.
Speak up.
Good evening and happy new year to everyone, especially to Binu ma'am. Right now, actually, I am at home only, so I'm not on the camera. My team, 40 of them are attending the session right now. And it was a very good session and knowledge sharing. Everybody talk about the technology, manpower utilization, skill development, all the topic we have covered. But again, one more thing that lastly, what Vinimam was telling that patient and family education is one of the most important topic I feel, because right from the beginning, when we become the nurse, we do say the patient and educate them after giving the cannula. If there is any pain or any redness, immediately call us, let us know. That practice even we must continue, because that is more important. They are the first point. So the early identification and early the intervention is very important to prevent the complications. And the right line and right therapy is always used that is the education to the nurses and knowledge about the therapy that should be given to the nurses. That is also very important. And the rest of the all, in fact, all the topics are already covered. So I'm very glad to share only this few things. And thank you so much.
So thank you, Mary, for adding patient and family education. Empowering patient and empowering nurses is the key to success. I do remember a quote. A successful leader is successful only when his team is successful. So we have to make our team successful. Only then you stand safe as a nursing leader. Only then you can do justice to your job, to your position. Yes, Pooja, over to you.
Yeah, ma'am. So Ananta Varshini, ma'am, chapter chair, Chhattisgarh chapter. Ma'am, you are there?
Hi, Ananta.
Yes, good evening. Good evening to all.
Good evening.
So happy new year to everyone. And like I have in between, I joined in between. It was so engaging. Thanks to all the speakers and officials and Binu ma'am and to Polymed. And like if we have to say, every breakthrough in the healthcare comes with a very simple question that how can we do better? So IV Talks is one such platform where it invites us to rethink, reimagine on the innovations and how to adopt it to deliver a better care. Uh, on the infusion practices, how smart and safe can we deliver the IV practices. So with that, I would say thanks to everyone, and we are looking forward for much more IV talks every month. And we will be contributing from our
We
chapter.
already have the calendar starting with RTM in January. Entire year's calendar is just been done along with Polymer team. So we are ready. We just want you all and our team of nursing to be ready. We are ready from INS.
Yes,
And
ma'am, we are
Polymer.
ready to.
Thank you,
Yeah,
Ananta. Yeah.
thank you.
There's a quick trivia question that Ipshita has prepared, which is about knowing how many chapters we have of INS India across India. Ipshita, you can put it in the poll.
Put
Let's
it in
see.
the poll for the audience.
Yes, yes, yes. We'll be knowing how many of us know that how many chapters we have.
People are
Ma'am,
reading. Yeah.
we also have Miss Niketana. Nikki, you can you hear right now?
Hi, Niketna. Where are you? You are one of my brightest chapter chair.
Probably we are starting the IV talks with Punjab itself. So
Yeah,
February
the
we would be
next
host.
month is Punjab.
Yes, so Punjab would
Yeah.
be hosting.
Punjab just did 2 activities for the infusion week. Okay, can you take the poll, Ipshita, for the audience? Are people answering or they are putting in the chat
Yes, ma'am.
box?
I just launched the poll. I'm checking, ma'am.
Okay, okay.
Right. And there is a question in the Q&A box. We missed it. It was from Dr. Bhargav, Dr. Atul Bhargav. One second. It was
What's the
related
question? Can
to
you
the what steps are taking to resolve biofilm recognition and treatment. This is a question which has come up in the chat box around
There
8 minutes
are
back.
innovations from the industry partners on biofilm. For the impregnated hubs are there. There are all of those things available, very easily available, and it's already practiced in India. Yeah.
Right. So the poll is there in the chat box itself. 15, 16, 17, and 18.
So that is the number of chapters in IN standard of practice. Wow. Please, everyone in the audience, 280 or 70, I don't know how many logged in numbers we have. By the
Most
latest
80.
standard of practice, we have got 2025 edition already available for a printed version. Those who are members can access it on the INS website, read-only version. Others can buy it. The book is only at 2,000 rupees. Those who are applying for Infuse get it complimentary. And please go read it. None of you are correct.
No, ma'am. The question is, how many chapters does INS India has? City chapters,
So
state
please,
chapters.
how many INS India chapters? Okay. Okay.
So 18
So
is
who
almost,
wants to
yeah.
take up that before I take up? I can count all the chapters. So we have got INS Delhi NCR, we have got INS Punjab, we have got Uttar Pradesh, we have got Rajasthan, we have got Gujarat, we have got Madhya Pradesh, we have got Chhattisgarh, we have got Hyderabad, we have got Tamil Nadu, we have got Kerala, we have got Karnataka, we've got Kolkata and East, we have got Guwahati, we have got Bhubaneswar going to be shortly, Odisha chapter. These are the existing chapters. There is a Goa chapter. It is not active, so I'm not listing Goa. And on 28th of this month, we are planning to launch INS Uttarakhand chapter. We'll be finalizing it tomorrow. And also for the audience, we are launching a 6-week certificate program of vascular access device management. It is ready. We will be launching it on 28th at Uttarakhand in one of the hospitals. And so all who want to enroll after that can enroll it through the website. We will float all the links. And I want more and more chapters to be formed. And we look forward to more engagement from each chapter, a quarterly activity. That is what we have for INS chapters.
Right. So
Okay,
I guess
guys, we are
Thank
at
you, ma'am.
4:58. We started on time. We are closing on time. That is Army standard. Multiple people here are from the armed forces, and Polymed is also a stickler for time. Thank you, everybody, for a fantastic, engaging discussion. Thank you, Dr. Lata, Captain Madhukari, Ms. Dolly, Ms. Saino, Ms. Madhvi. And thank you, Mr. Sondi, Dr. Atul, and Pooja from Polymed. And thank you, our very, very engaging and inquisitive audience. Fantastic. Thank you very much. And I'm Colonel Binu Sharma, part of INS India. Thank you.
Thank you, ma'am. Thank you so much.
Yeah.
Thank you very much. Thanks a lot.
Thank you.
Thank you so much.
Thank you,
Wonderful
ma'am. Thank you.
opportunity.
Thank you, ma'am.
Thank
Thank
you.
you.
Thanks, the
Thank you.
audience. Thank you, ma'am.
Thank
And
you so
audience,
much.
please stay connected.
Everyone.
We will be connecting next month
Audience,
for
we
the
want more and more people, more members, more infuse, more people reading the standards. And thank you once again. And best wishes
Thank you.
for your
Thank you.
professional and personal journey going ahead. Thank you.
Thank you.
Thank you, Binu ma'am. Thank you.
Thank you,
Thank you.
ma'am.
Thank you,
Thank
ma'am.
you.
Thank you,
Thank
Dolly
you.
ma'am. Thank you, Madhukari
Thank
Thank you,
you so
ma'am.
Saina
much.
ma'am.
Thank you.
Thank you, Madhvi ma'am.
Bye.
Lata ma'am.
Bye.
Thank you. Thank you. Bye-bye.
Bye, everyone. The audience is continuing to send thank you, so we'll.